In the late 19th century, a leading theory as to why seizures occurred had to do with the blood flow to the brain. Too much was not a good thing. So efforts were taken to reduce cerebral perfusion, including carotid compression and eventually electrical vagus nerve stimulation, with the hope of slowing the heart rate. But it wasn't until 100 years later that the first clinical trials began to confirm the safety and efficacy of this seemingly unconventional procedure. Why this works is still a mystery, but because it does actually work, we use these and other neuromodulatory devices in patients with intractable seizures. That's what we're going to talk about today, in part 2 of the minimally invasive non-brain surgical management of drug-resistant epilepsy. Happy Thursday, and happy Thanksgiving to all the listeners out there. I hope everybody's enjoying a little bit of a vacation to spend time with family and friends, and lots of food. Last year, Dr. Jason Maley and I did a show specifically centered around the neurologic complications of the food you might be eating at your Thanksgiving table, episode 37. So if you're looking for a reason to avoid eating Aunt Martha's famous personally preserved cranberry sauce, that show might teach you something about foodborne botulism and how to avoid it. So pull up that show in your podcast queue while we play this message from one of our sponsors.
This episode was brought to you in part by Audible, your source for audiobooks. With nearly 200,000 titles to choose from at the click of a button, Audible makes it easy to find time to catch up on stories. If you like this episode so far, then we know you will like The Man Who Mistook His Wife for a Hat and Other Clinical Tales by Oliver Sacks. You can get this audiobook and others like it for a free 30-day trial at audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
For this week's show on the Brainwaves podcast, I spoke with Dr. Danielle Becker, who's contributed to previous shows before. One of my favorites being the issues that are faced by women with epilepsy, episode number 26. And now she returns to talk about another interest of hers. You're kind of the local expert at Penn, I would say, for some of these neuromodulatory devices for drug-resistant epilepsy. What got you interested in these devices?
So in general, 3 million people have epilepsy in the United States. Of those 3 million people, approximately 1 million people, or a third, have intractable epilepsy or drug-resistant epilepsy, which means that they've tried at least 2 medications at optimal doses and continue to have uncontrolled seizures. As a resident and a fellow, I was introduced to the vagus nerve stimulator, VNS. The thing about neuromodulation is that there's a relationship with time, and the longer the patients have these neuromodulatory devices, the better the outcomes appear to be. In addition, there are other outcomes that are not as clearly stated, but are important to the patient, like improvements in cognition, attention, memory, which I also found very interesting because, as you know, when we use our anti-epileptic medications, a lot of those particular quality of life measures are hindered and not improved.
Specifically, what Dr. Becker is referencing here are the side effects of AEDs, which can be intolerable, especially as you start increasing the dose to near toxic levels, or adding second and third line drugs to a patient's regimen.
The side effects can include sedation, issues with concentration, sometimes with tremor, sometimes with dizziness, imbalance, rashes, and these side effects can be disabling and impair function in their everyday lives.
Toxicity is not all that's important. There's also efficacy, which we discussed in the Quanta episode recently. Adding a third drug only gets you 3% closer to seizure freedom, and a fourth drug, that's less than 1%. So we need something better for these patients, and if not brain surgery, then what? Cue the vagal nerve stimulator, or VNS.
The VNS is a device that essentially is always on, responding in a periodic manner. So it may be on for 30 seconds and off for 5 minutes, but it is a continuous cycling response. We call it an open loop response because it's continuing to go in the loop and nothing is changing its responsive network.
Well, nothing, until the patient feels like a seizure may be coming on, if they experience an aura or something. Then the patient's given a magnet, and they're instructed to swipe the magnet over the device, which is implanted beneath the skin of the chest, and then the device will send an impulse to the vagus nerve, hopefully to abort the seizure event before it even starts. And by signaling through the peripheral vagus nerve, it seems to stop potential seizures in a very non-specific way.
And the vagus nerve broadly treats where the seizures are coming from. It is not specific to what region the seizure is coming from.
The history of these devices is pretty interesting, especially knowing how little we still know about the VNS. Originally, neuroscientists like the American James Corning in the late 1800s believed that seizures were precipitated by increased cerebral blood flow. The English physician Caleb Perry in the late 1700s had observed facial flushing and bounding carotid pulses in patients who were having seizures, and he proposed that direct carotid massage would stop the seizures by reducing blood flow to the brain. This became a standard of practice at many institutions throughout the 19th century. The development of a carotid truss, which would apply pressure to the carotid arteries in seizure patients, actually looks like a torture instrument from the movie Saw.
Hello, Amanda. I want to play a game. Here's what happened.
And scientists like James Corning felt that the vagus nerve stimulation, among other things, could reduce cerebral perfusion by slowing the heart rate, thereby reducing seizure frequency. That was the thought, anyway. Side effects of transcutaneous carotid and vagus nerve stimulation included the expected Horner syndrome of mydriasis and ptosis, as well as symptoms of cerebral hypoperfusion like dizziness, generalized weakness, and syncope. However, Corning continued to promote his methods. According to his records, and I quote, "I have great hopes that this form of treatment may prove of value in epilepsy, although my experience with it in this connection is still too limited to express a positive opinion as to its ultimate value as a therapeutic measure in this disease." As Corning acknowledged here, his treatments did not produce consistently positive results. They were not widely adopted by his colleagues, and ultimately they were abandoned in the late 19th century. As it turns out, vagus nerve stimulation paradoxically increases cerebral blood flow, and this probably relates to the anatomy of the vagus nerve. A common misconception to it is that the vagus is a largely efferent nerve. However, 80 to 90% of the fibers in cranial nerve 10 are actually afferent fibers, and they project up to the nucleus of the solitary tract.
No one knows exactly how it works. There are some hypotheses that the locus coeruleus is involved. There's other hypotheses that it modulates the thalamocortical projections, increasing GABA neurotransmission in the brain and can help stop seizures, and decreasing glutamate neurotransmission in the brain, which is excitatory and can exacerbate seizures.
And unlike the more neurosurgical options for refractory epilepsy, like Dr. Abdenator discussed, VNS exists outside of the central nervous system.
It has a wire that curls around and stimulates the vagus nerve and sends a response up to the brain.
So, by stimulating the left vagus nerve with a small intermittent current, it's thought to somehow reduce the synchronization of brain waves that propagate into electrographic discharges, and ultimately into seizures. And we've observed this benefit in a number of clinical trials. When epileptologists think about the VNS and its efficacy, two major clinical trials come to mind, EO3 and EO5. In EO3, which was an international clinical trial, 113 patients were implanted with the VNS and randomized into two groups, high stimulation and low stimulation. The high stimulation arm in EO3 experienced a median 24.5% reduction in seizures, compared to 6.1% in the low stimulation arm. In EO5, the US multi-center trial, 199 patients were also randomized to high or low stim. Similar results were observed, with higher stimulation being more effective at seizure control than lower vagal nerve stimulation. The results from these and other trials were even more impressive at long-term follow-up, with fewer side effects that are reported over time. For example, using the outcome of seizure reduction by at least 50%, 23% of patients with VNS achieved this favorable outcome within 3 months of implantation. By 12 months, the 23% had grown to 37%, and by 24 months, 43%, where this number appeared to plateau. So nearly half of patients with refractory epilepsy can achieve a seizure reduction by over half with this device, if they are appropriate surgical candidates for this type of implantation.
It has a very wide indication. It can be used for focal or multifocal epilepsy.
Again, this is Dr. Miriam Abdenator from last week's show.
It can prevent some drop attacks in generalized epilepsies in Lennox-Gastaut, and it's used for some genetic epilepsy syndrome like TSC. Its side effect profile is low, and it's considered pretty safe.
The most common side effects of VNS are vocal changes in 60% of patients early on, which makes sense given the often concurrent stimulation of the recurrent laryngeal nerve, which is involved in phonation.
One of the most common side effects is either hoarseness or coughing.
And less commonly, patients will experience headaches and paresthesias.
Other patients may state that they have shortness of breath, maybe while exercising with the VNS. And if that's the case, they actually can tape their battery over their device when they go for exercise. And that seems to alleviate that symptom as well.
Again, these risk factors often fade away after several years of continued treatment, except for the vocal changes, which persist in about 1 in 5 people. Interestingly, you'd think that there might be a higher risk of cardiac complications from a hyperactive left vagus nerve, as it signals the atrioventricular node. Remember, the right side of the vagus innervates the sinoatrial node, and the left vagus innervates the AV node. But the FDA has only approved stimulation settings for the VNS such that these cardiovagal side effects are minimized or even eliminated, which is why events like asystole are estimated to occur in less than 1 in 1,000 people, according to some older data. So, a rare complication, but something that must be disclosed to patients preoperatively. As it stands, VNS may be considered for seizures in children, for LGS-associated seizures, and for improving mood in adults with epilepsy, according to 2013 AA guidelines. Largely, it's indicated for primary generalized epilepsy syndromes in children and adults. But VNS is not all that's out there. The second device we're going to talk about is deep brain stimulation, or DBS, which is kind of like the intracranial version of VNS. The concept is somewhat similar, and several locations for DBS have historically been attempted, many just in small case series, with very few in controlled clinical trials. Perhaps the most widely targeted region for neurostimulation is the anterior nucleus of the thalamus, which is involved in the PAPE circuit. This is best supported by evidence from a randomized, controlled crossover trial published in 2010, in which 110 patients underwent bilateral anterior thalamic implantation of a stimulation device and were randomized to 4 months of stimulation or no stimulation. Again, we're talking about continuous stimulation and not responsive neurostimulation. After 4 months of monitoring, the stimulated group had a statistically significant absolute risk reduction of seizures of 29% versus the control group. At this point, the arms were unblinded and everybody's stimulation device was turned on. The survival curves for treatment responsiveness then merged, and there were significant falls in seizure recurrence for both groups. By 2 years, 54% of patients had a reduction in seizure events by 50% or more, which you'll recall is perhaps slightly more than the response rate that's observed in prior trials of VNS for drug-resistant epilepsy, where 43% of patients responded to stimulation. But we are comparing apples to oranges here, so it's not really all that appropriate to compare these numbers between trials when the patient population and the methods were so different. Lastly on today's talk, we get to the pièce de résistance, responsive neurostimulation. While VNS and DBS are equivalent to the pacemaker for the brain, a more elegant solution is also possible for adult patients, the responsive neurostimulation system, or RNS.
It's considered a smart device. The RNS system is the only device that monitors and responds to brain activity to help prevent seizures. It treats abnormal electrical activity in the brain in order to prevent seizures. And it does this by constantly monitoring or looking for any abnormal electrical activity. Once it sees that electrical activity, or once it detects it, it then responds within milliseconds with a brief electrical pulse to try to return the brain waves back to normal, and ideally to avoid a clinical seizure.
Unlike DBS, which targets a central location in the brain, like the anterior nucleus of the thalamus, RNS electrodes are placed elsewhere.
There are electrodes in the brain that are placed in the seizure onset zone. So it is targeting where the seizures are starting and sending a stimulation in response to abnormal activity.
Patients have a small battery attached to their skull, and they would upload the data from their house to the network, and the epileptologist can look at their data, and when they come to clinic, we can reprogram their device for a better efficacy.
And while VNS is like the pacemaker for the nervous system, the RNS is like a defibrillator, shocking the system back into normal function whenever things go awry. Dr. Becker has another analogy for it.
So one of the analogies that I use with patients is thinking about a hall monitor. So if you think back when you were in middle school or high school, there was usually someone who may have stood out in the hallway, especially between classes, monitoring for any abnormal or disruptive behavior. The RNS device represents that hall monitor.
So it wouldn't necessarily prevent the onset of bad behavior, but it would stop it in its tracks.
Correct. So initially, it's thought to stop it in its tracks, and over time, it's thought to use neuromodulation to potentially stop seizures before they start. But at this point, the goal is to detect the seizure as early as possible and stop it from becoming clinically evident to the patients.
And something that I found interesting about RNS is that this technology has allowed us to detect an entire spectrum of subclinical seizures that we would never have known that the patients were experiencing. So the seizure burden in these patients is even greater than we knew before.
So that is correct. So the interesting thing about how we used to treat epilepsy is that a patient would come into the office and we would be talking with them.
How are you? Fine, thanks. What's the problem today?
And we'd have to rely on their memory to tell us what seizures they have. And studies have shown that patients are not always aware of their seizures, and even when their seizures are clinical, they're not always aware that they've had a clinical seizure unless someone else is there to witness it. So this device has shown that the concept is correct, that patients using the device are found to have many more electrographic seizures than clinical seizures reported. And when we start a new medication, often we have to wait 3 or 6 months to see if it potentially is helping the patient. With the data you can get from the RNS, you might be able to tell in the first 2 to 3 weeks if the detections have decreased.
Unlike DBS, RNS only delivers an electrical impulse when a seizure is detected. In the first landmark trial of RNS, published in 2011, investigators demonstrated a reduction in rate of seizures by 39% at 1 year and 51% at 2 years in a cohort of 191 patients with drug-resistant epilepsy. Important to note here is that, like VNS and DBS, the effect seems to improve over the first several years of treatment. But unlike the typical plateau that's often seen with VNS at 2 years, RNS continues to increase in efficacy. And at follow-up 7 years later,
patients experience an average of 72% reduction in seizures.
The effect builds and builds over time.
A quarter of these patients have a seizure reduction of 93% or higher.
90%.
Also, although it's not typically a curative procedure, almost 30% of patients who are implanted with the RNS device report at least one 6-month period of seizure freedom.
Now, remember, the patients who were included in these original trials were patients who had drug-resistant epilepsy. They continued to have clinical seizures despite being on at least 2 therapeutic anti-epileptic drugs for a substantial period of time. And now we know that they've had countless more subclinical seizures because this device is telling us this information. Now, all of a sudden, their average seizure counts are dropping precipitously, and a substantial number of patients are going on to seizure freedom. Then there's also the mortality benefit.
And it has been found that patients with this device have a reduced risk of sudden unexpected death in epilepsy.
A reduction from about 9 per 1,000 patient years to 2 per 1,000 stimulation years. A relative risk reduction for nearly 80% for mortality.
And that's our ultimate goal in these patients who have uncontrolled, intractable seizures.
While the mortality benefit is a really nice perk to these minimally invasive devices, there are also safety concerns that patients should be made aware of that are more common. In terms of the overall safety profile when it comes to neurostimulation, the VNS is probably safer due to the lower risk of any sort of brain-penetrating procedures. From data on patients with Parkinson's disease who undergo DBS, the risk of stroke or hemorrhage at that site is about 1%, similar to the risk of subdural or perioperative hemorrhage. And the risk of intracranial infection is just under 0.5%. But the risk of intracranial infection does seem to slowly go up over time. And while these numbers may seem low, compare them to 0% for VNS, because it's not an intracranial procedure. And RNS, unlike VNS, may not be safe in MRI scanners.
Unfortunately, this device is not MRI compatible yet.
So you won't be able to repeat more advanced neuroimaging in these implanted patients. VNS is also more cost-effective than RNS, because it's not brain surgery. Still, when you do the math, either are going to be far less expensive than the lifetime costs of managing a patient with uncontrollable epilepsy on AEDs. So, efficacy, safety, and cost are all part of the equation when you're reviewing the risks and benefits of each device. But when Dr. Becker talks to her patients, she takes a more personalized approach.
Whenever I am talking about surgical options with my patients, I talk about all of the options. So that includes the VNS, the RNS, surgical, and it includes medications. And so it really depends on the patient because patients have different risk profiles and different goals. A patient may say, with my job, I cannot afford to have any change in my cognition. They don't want to risk any even slight cognitive deficit, and thus do not want to have any tissue removed, whether it be by laser or resection. They would rather try a device that acts on the seizures without any removal of tissue. And that is what the RNS provides, and the VNS in a broader sense as well.
Then there are also the obvious anatomic contraindications to surgery or other types of brain manipulation.
Any patient who has a seizure coming from eloquent cortex or any patient who has seizures coming from more than one spot would be a candidate for the RNS. Now, the VNS is used in patients with both partial and generalized seizures. So that is the difference, is that the VNS is used in patients with generalized epilepsy, and actually that is where it's shown to have the most efficacy.
So for partial onset epilepsy, the RNS is highly effective and has FDA approval for use in this circumstance for adults only. Whereas for drug-resistant primary generalized epilepsy syndromes, the VNS is recommended, and it can be used in children and adults.
The VNS is a great tool for these patients with generalized epilepsies that have not been well controlled with medications.
Can a patient undergo a combination of these procedures? Like, can they go for responsive neurostimulation and then eventually anterior temporal lobe resection, or does that not happen?
That's a great question. So just talking neuromodulation, a patient can have both a VNS and an RNS. I have 4 patients who have both devices. Now, often, just because of the trajectory of time and the fact that the VNS has been around for almost 20 years, and the RNS was approved by the FDA in November of 2013. A lot of these patients who did not respond to medications then were referred on for VNS.
It turns out that in one of the earliest trials of RNS, published in 2011, 34% of patients had previously undergone VNS implantation, and 32% had already had prior epilepsy surgery, like anterior temporal lobe resection. While that goes to show you just how poorly controlled their seizures were, since they were still having frequent breakthrough events, it also proves the point that patients may be considered for multiple treatment modalities and have both VNS and RNS, for example. There are no contraindications for this.
And I have one particular patient where the VNS and the RNS work synergistically together. The VNS controls their right-sided seizures and the RNS controls their left-sided seizures. To the point where when the VNS battery died, my patient all of a sudden started having right-sided seizures again that we had not seen for the first year the patient had had the RNS device. As soon as the VNS battery was replaced, the right-sided seizures no longer appeared either electrographically or clinically.
There is another benefit to monitoring for seizures using the RNS, and that's the fact that RNS allows for real-world event monitoring. Like Dr. Becker said, we typically rely on our patients to recount for us their history of clinical events. Are they happening more frequently or less frequently in recent weeks, and what happens when we titrate meds? And if we can't be sure that the interventions we're using are helpful for these patients, or if we want to better characterize their events, we often bring these patients into an epilepsy monitoring unit. Now, the EMU is a very unnatural setting. The beds are uncomfortable, alarms are going off all the time. We are trying to stress them, mind you, but we're also taking them out of their typical day-to-day life. We wean off their anti-epileptic medications, we sleep deprive them, we stress their bodies with photic stimulation and hyperventilation in many cases, and these may precipitate seizure events that aren't typical for the patient. And if we find a string of seizures in this unnatural setting that originate from a single area of the brain, we might pat ourselves on the back and say, we figured it out. But in some cases, there may be more than one epileptogenic focus, and these can take 40 or 50 days of monitoring to identify.
So one other thing to add about the RNS is it's a device that is personalized to the patient and their seizures. It's basically used to fingerprint their seizure pattern individually and send stimulation that is specific to their patterns. I liken this to when you first get a new iPhone, if you want to use the Touch ID. And when you think about it, you don't just put your thumb on the iPhone once. You have to put it on and take it off several times, roll it around, make sure that the device recognizes all the folds of your fingerprint. That's kind of how the RNS works as well. Initially, we capture seizures and we turn on the device after seizures are captured, and we program targets to help identify this seizure at its earliest onset. However, over time, as more seizures are captured, we continue as the physicians to tweak the detections and get better patterns for picking up the seizures at their earliest possible stage.
I love all these analogies.
Thank you.
Thank you so much, Dr. Becker, for being on the show. I really appreciate your time.
Thank you very much.
Dr. Danielle Becker, everybody. And thanks again to Dr. Miriam Abdenader of the NIH for her comments this week as well. For more information on what was discussed today, check out the blog at brainwaves.me. There is a great review on RNS and neuromodulation in a 2013 Continuum article by DeGiorgio and Krall if you're interested. And references for this and other selected articles can be found in the show notes. The episode this week was produced by myself, Jim Siegler, music by Chris Zabriskie, Josh Woodward, and Kevin MacLeod. And that wraps it up. Take care, everybody.